and now I invite Dr. Vineet Ratra. He's going to present some cases on lens extraction in PACG. Vineet?
So, thank you very much, Dr. Vinay Nangia, for having me. And after hearing all this, makes my work much simpler. I'm going to be talking about just two cases. Actually, it's more of an acute angle closure attacks, where you had a 55-year-old gentleman who came with pain, watering, redness, nausea, headache, classical symptoms. He had no vomiting and he was asthmatic. No family history of glaucoma, and he came to the emergency. This was all in his left eye. His his uncorrected visual acuity was 6.6 and 8 in the right eye, and 6.60 and 8 in the left eye. Right eye, the pupils were normal, no RAPD. Left eye was mid-dilated, not reacting. Slit lamp examination of the right eye just showed a shallow anterior chamber, whereas the left eye, there was circumciliary congestion, there was microcystic edema, and intraocular pressure was 16 in the right eye, was 44 in the left eye. Gonioscopy of the right eye was occludable, left eye hazy view, so the gonio was not done, and he had an acute angle closure glaucoma attack in the left eye, and he was right eye needed a YAG peripheral iridotomy. So he was given oral acetazolamide, started on steroids, mannitol given, his intraocular pressures came down. He was asked to review the next day for YAG PI. Sorry. Unfortunately, he developed COVID, got admitted into a general hospital. So a tele consultation was done. He was asked to take acetazolamide and pilocarpine eye drops by twice a day, consulting with the ICU people. He presented nearly 10 days later. His intraocular pressure on these medications was okay. He was advised a YAG peripheral iridotomy. This was done by a colleague. And following that, his anti-glaucoma medications were stopped. His pressures were okay. His fundus in both eyes was normal. He presented to me nearly 10 days later, and without medications, his pressures in the right eye was 18 and in the left eye was 34. So we did discuss. We told him we'll do a OCT, we'll do a UBM, we'll do a lens star, and then we will review. So we did a UBM, and the UBM just showed some small size cysts in the right eye. Angles were open, and in the left eye it was again some cysts, and the angles were closed. They noted that the PI was patent. So this was the OCT. The left eye did have some disc swelling, and this was his lens star. So you had an axial length of, I'll stick to the left eye, of nearly 24, aqueous depth of 2.28, and a lens thickness of around 4.66. We did his gonio again, and we could see that 3 quadrants were closed, only 1 quadrant was open in the left eye. So we advised him, discussing the various options, we did advise him phacoemulsification with an intraocular lens. Preoperatively, his intraocular pressure, which started him on IOPAR, was 14 and 28. So he underwent an uneventful cataract surgery, and he developed, we gave him just IOPAR on the day of surgery and Predford 4 times tapering, megabrom. I generally dilate my patients with atropine twice, once in the night before and once in the morning. He had developed an epithelial defect, so on the 3rd postoperative day we checked his intraocular pressure, and it was 8 once the epithelial defect had healed. So 3 weeks later, when he came for his final checkup, his vision was good, 6.6 and 6 in both eyes, and intraocular pressure was 15 and 21 millimeters of mercury, and there were just a few scattered PAS. So we told him, yeah, maybe reduce your steroids faster, and let me see you again in 3 weeks. His pressures were even lower, 18, and a month later they were 14. So we asked him to review again after 3 months, and his vision maintained. His intraocular pressure was 13 and 12 in the right and left eye respectively. His fundus remained, the discs remained healthy. So if you were to look at the course of his intraocular pressure through the different stages, it was like this. So this is our EMR screenshot. So you can see he had high pressures which slowly started tapering down and maintained along with the left eye. So I'll show a second case. This patient was diagnosed as an acute angle closure attack elsewhere. We started on IOPAR, and along with that dorzolamide and timolol. You don't need to actually combine topical and oral carbonic anhydrase inhibitors. She was a hyperope. She was around 67 years old. Her rest of the examination was okay, but she had CCC, circumciliary congestion in the right eye. The anterior chamber was shallow, and she had maybe early cataract. Intraocular pressure on these medications was 10 and 12. There was no relative efferent pupillary defect. And the gonioscopy, you can see this is the nasal angle. This was with a 3 mirror, and you can see that it is closed. The rest of it was open on compression. These are her disc photos. There was a optic nerve head swelling, but more or less healthy. This was her OCT. The left eye did have an epiretinal membrane. So this was her lens star calculation. So in the right eye, her axial length was 22.76, aqueous depth of 1.62, and a lens thickness of 4.85. So I'll just run through this. We did a cataract surgery in her. The surgery was uneventful. And so once you put the lens, you can see there is some amount of phacodonesis. So we did an intraoperative gonioscopy in her just to see what happens, and you can see that the nasal angle has opened up. There is a little bit of pigmentation, but we could easily see that the angle had opened up. So this is the pre-op and the intra-op picture. She underwent cataract surgery subsequently in the other eye, and her pressures were maintained post-operatively, and these are her pictures post-operatively. About her OCT, the disc swelling had come down in the right.